Dear friends, colleagues, and members of the Bárány Society, welcome to the true kick-off of the 31st Bárány Society meeting. Of course, we should have to meet 1 year ago, and here we are just 9 months ahead of the meeting. We should have to meet face to face, and we are here online. So no one, I tell you for true, no one ever thought this should happen in our worst scenario 1 year before the meeting. We were thinking in many things, unless a pandemic. And so we have to make it. And of course, we are working in the health system, and many of us had to reinvent ourselves, the way we see the patients, what type of patient we see, how we work at the emergency room, at the intensive care unit. Many of us also were in the back of our colleagues making tracheostomies in the surgery. We are seeing new things, new problems. We are trying to rehabilitate them. So this scenario never was thought by any of us, but here we are. Let me tell you that we were just at some point thinking, okay, finish and we forget the meeting. So let's see who wants in 2022 get and organize the 31st Bárány Society meeting. But we thought we got an appointment in 2016 in Korea, so we said that's for us. So here we are, just trying to do our best. Of course, first I have to give thanks to the Bárány Society. Goran Laurel has always given all his support, and his closest group, Mans, Nicolas, they were always giving us some kind of freedom for the organization, all the support, all the ideas, all what we were trying to tell them, or at every time was accepted. And of course, that made us to continue in this effort. In the organizing committee, Eduardo Martin and José Antonio López Escámez, they have been searching all this time also how the things are evolving in the scientific world. I mean, everything is, up to now, COVID-19 is not all the things. So we are now seeing new papers in dizziness again. So that everything is coming to its previous state. We are moving, and this is an idea we want to share with all of you. The organization of the meeting in May is going to be on May next year. As you know, the dates are in the website. We're moving from a completely online meeting to a hybrid meeting. We want we want to meet one each other. I mean, that's for the meetings. But we want to be safe. So we want to keep some online material and some face-to-face material, because we don't know what's going to happen. This is a very changing environment. So if we go again for a completely face-to-face, we can meet ourselves again with another problem like this. Today, we have learned, or yesterday, that the US will change their limitation, their travel restrictions in November for Europeans. And I think this is going to make it easier for the next year. But anyway, we have to be very careful with what we do, because we want the meeting to be safe. And Madrid is becoming an extremely safe city after the extreme bad time we lived in March last year. The meeting has to be not only scientifically high but safe, but also must take in account the economic situation. I think the world is changing. Things are not so good as they were before, and it will take a long time to be as they were, if they come to be as they were. So we want to make the meeting not only safe, sound knowledge, but also available for everyone. And we consider that the economy is going to move. And this is extreme hard work we are doing with the scientific, with the technical secretary Travelmed, to which I also have words of gratitude. And we want to make it for everyone. The first thing we made, it was how can we make the people aware of the Bárány Society meeting? And then Alex Bisdorff said, here am I, here I'm gonna help you. And so he made a very interesting scientific meeting. The only issue is that it is online with the good and the bad things of it. But of course, he said, I want to be an appetizer of the true Bárány Society meeting. And I think he made it. I mean, this is an appetizer, typical Spanish appetizer. You don't know if it is better the appetizer or the lunch, but at least the appetizer is very good. So I think we are going to spend a very nice meeting. I have to give thanks to all the participants, and so happy to see them here, that of course I am waiting now to May to come, and of course see you all face to face and embrace everyone. So thank you very much, Alex, and of course thank you very much the participants. Sorry for putting you on the second time, but I think everyone, I've been talking last weeks with people here in Spain, and we began with a very modest 30 persons. I think we were almost close to 200 in the last week. And that means that not making so much publicity, and we have 200. Our floor is very important. And that floor is gonna spend a couple of days very interesting. So thank you very much to all of you. Please, we want to be on time for everyone, but remember that some of the issues that will take place on May, we are not able to consider by now, although we are going to try to make the best meeting, not ever, but at the end for this new era, new time after pandemic. So thank you very much, and thanks for your patience very much. Alex, I'm finishing here.
Well, thank you, Nicolas, for this kind introduction. Well, it is a pleasure for me to introduce a meeting as an appetizer, as you are mentioning. This meeting was done because the postponement of the meeting for 2 years, we thought we should do something in between, and so we had come up with the idea to present the classification of international classification of vestibular disorders. This is a long process going on for already more than 10 years. The first publication came out in 2009. The building of the classification follows a rigorous procedure to achieve the highest standards possible for having definitions which should be clear and applicable worldwide in a reproducible manner. The different definitions are elaborated by dedicated subcommittees under the lead of an opinion leader in that very topic it is about. And this person is free to compose the subcommittee with other leading experts with a request that in it should be represented at least one ENT doctor, one neurologist, and 3 continents. The subcommittee has to consider the most up-to-date information available and build a consensus around the best evidence available, which also includes pointing out limitations of current knowledge and areas of uncertainties. The subcommittee delivers then a draft definition and then starts an internal review process. And this internal review process comprises that it is reviewed by what we call a classification oversight committee, which is composed of the present and past subcommittee leaders, which I'm honored to have the chair. After that, drafts are put online on the Bárány website, on the website of the Journal of Vestibular Research, where it is accessible for Bárány members, and they can give their comments. And after getting these comments, the final definition is then published as an online and open access publication on the website of the Journal of Vestibular Research, which is the Bárány Society's scientific journal. This process, when you start it in a definition, usually looks easy and quick to achieve, but so far, every time, it has never turned out to be like that. It has always turned out to be quite complicated and a long haul. And I think we have maybe managed one in a year, but usually it takes a few years to do. Now, it is a pleasure to chair this session, which is dedicated to the presentation of a selection of recently published definitions. And you have the privilege that these presentations are done by the leaders of the respective subcommittees. They are in the best position to present the work and also to give you a feel maybe of the obstacles and difficulties you have to overcome. And then you can ask them questions via the chat function, and I will forward them to your questions to them. So we have definitions of vestibular disorders, but we also published one definition on clinical science. And this is what we are starting with. You are all aware of the importance of eye movement examination in vestibular disorders. And that's why we also decided to do a classification on nystagmus to harmonize its nomenclature. Not all nystagmus is of vestibular origin, but knowing nystagmus well and also the different kinds which are not necessarily vestibular is important if you do your differential diagnostic considerations. So be aware that the different presentations have been pre-recorded, but all the speakers will be there live to take your questions and to give their answers. So we will start with the first presentation, which is given by Scott Eggers on nystagmus. Professor Scott Eggers is an associate professor of neurology within the definition, the division of education at the Mayo Clinic in Rochester, Minnesota, USA. He is originally a neurologist, but then subspecialized in otoneurology and in the dizziness and balance program of that of his hospital, the Mayo Clinic, where he is a member of staff since 2003. He has a large clinical interest and also research interest in disorders causing dizziness, vertigo, nystagmus, diplopia, ocular motility impairments, and also does some general neurology. He also is a medical editor of Ask Mayo Expert, an online tool to provide rapid point-of-care clinical answers to healthcare providers throughout the Mayo system and Mayo Clinical Care Network. He also has received, it also serves in various institutional, societal, administrative, and educational roles. So, Scott, we are curious about your talk, which is going to start now any moment.
I'm Scott Eggers, and I'm a neurologist at the Mayo Clinic in Rochester, Minnesota. And on behalf of my co-authors from the Bárány Society, I'd like to present to you today our work on the classification of nystagmus and nystagmus-like movements on behalf of the International Classification of Vestibular Disorders. And our learning objectives for the talk today will be to clarify terms for characterizing the attributes and influencing factors of nystagmus, to classify and organize the complex nomenclature of nystagmus based primarily on phenomenology, to demonstrate some common and uncommon forms of nystagmus, and distinguish nystagmus from other nystagmus-like movements, and briefly discuss pharmacologic treatment of some nystagmus types. This paper and all of the other classification papers can be found on the International Classification of Vestibular Disorders website that's hosted by the Journal of Vestibular Research. And we'll begin first with definitions. Nystagmus is an involuntary, rapid, rhythmic, oscillatory eye movement with at least one slow phase Jerk nystagmus is nystagmus with a slow phase and a fast phase, while pendular nystagmus is nystagmus with only slow phases. And nystagmus differs from saccadic intrusions and oscillations, such as square wave jerks, ocular flutter, and opsoclonus, in which inappropriate saccades take the eye away from a target during intended fixation rather than a slow phase movement. And it's important as we examine nystagmus and as we document it in our notes that we describe all eye movements from the subject's vantage point. We do this intuitively for rightward and leftward eye movements. And we also need to be particularly careful as we describe torsional direction, because this is a common source of miscommunication. As we describe torsional eye movements in the coronal or roll plane or around the naso-occipital axis, it is most unambiguous to describe how the top pole or 12 o'clock position of the eye rotates toward the patient's left ear or right ear. But if we're going to use words like clockwise or counterclockwise, we also need to be quite clear that we're referring to clockwise from the patient's perspective and not the examiner's perspective, as is commonly done. It's also useful often to clarify the coordinates or the reference frame in which we are seeing the eye movements. For example, we may use an eye-referenced coordinate system or describe eye movements along the visual axis, such as, let's say, downbeat nystagmus that continues to be downbeating with respect to the patient's visual axis, regardless of the eye position in the orbit. Alternatively, sometimes it's useful to use a head or canal referenced or labyrinthine coordinate system, such as eye movements that might align with the right posterior semicircular canal in BPPV, for example, where that condition activates a pair of eye muscles that move the eye in a mixed direction with a combination of a torsional and a downward eye movement. This remains the case whether the eyes are looking to the right or to the left, so the trajectory of the eye movement may differ with respect to the visual axis, but remains fixed in the orbit with respect to the orientation of the semicircular canal. So we might say that the eye movements align with the right posterior canal. And occasionally we use an earth-referenced coordinate system where we may say that there was horizontal geotropic nystagmus in the supine roll position. It's important to note whether the nystagmus is monocular or binocular, and if the eye movements are conjugate, meaning both eyes rotate together by the same or within the same plane and direction and by the same amount, or if the eye movements are disconjugate. And if they are disconjugate, they might be dissociated, where the amplitude or velocity of the oscillations is different in the two eyes, or they may be disjunctive, where the two eyes simultaneously rotate in different directions. And then, of course, it's important to consider the waveform of nystagmus. Various types of jerk nystagmus may be present, where the slow phase may be of a constant velocity, as we'd expect with a vestibular nystagmus, a decreasing or decelerating slow phase velocity, as we may see with impaired gaze holding, or even an increasing or accelerating slow phase waveform, as might be seen in infantile nystagmus. And if there are no fast phases, then we are dealing with pendular nystagmus, whose trajectory may be purely horizontal or vertical or torsional, or it may be elliptical or circular, depending on the phase relationship between the horizontal and vertical components. Some additional attributes to note would include trying to describe the slow phase velocity, which is often the most useful quantifier for really the intensity of the nystagmus, but is difficult to estimate at the bedside. Sometimes it's useful to comment on the frequency of nystagmus, or the number of beats per second. But this is mainly useful for very low frequency forms of nystagmus that are 1 or 2 or 3 hertz. We could describe the amplitude of the nystagmus, or in other words, the distance that the eye rotates in degrees in a single slow phase, but that generally provides very little useful information. More often at the bedside, we will qualitatively gauge the intensity of nystagmus by considering essentially the mathematical product of the frequency, beats per second, and the amplitude or the size of each slow phase beat, which is effectively similar to the velocity of the nystagmus. And we should note any influencing factors on the presence or type of nystagmus, and this would include gaze position. So the presence, intensity, and direction of nystagmus should be evaluated in the 9 cardinal gaze positions as well as in convergence. And then what are the effects of visual fixation, either during binocular fixation or with monocular occlusion or binocular occlusion, essentially removing visual fixation. And there are various methods to do so. We can close or cover one eye, perform occlusive ophthalmoscopy, or use the pen-light cover test, use Frenzels, examine the patient in the darkness, of course, with tools like infrared video oculography, or what's happening with the eyes closed. So if you are skilled with using an ophthalmoscope while looking for the optic nerve head, we can simply cover the patient's other fixating eye and observe for the presence of nystagmus looking at the optic disc. And so we may see spontaneously or with fixation removed that the patient develops jerk nystagmus in this case. And here we see that the back of the eye, the fundus, the fast phases are beating towards the patient's left ear. So of course the front of the eye would be beating toward the right ear, and we'd say this is right beating nystagmus. Alternatively, we can use a pen light. Here's Yoon-Hee Cha demonstrating the pen light test in a patient with an acute vestibular syndrome.
It's difficult to say that she's got a primary gaze nystagmus at this time. She's able to suppress it with fixation. Now look over here to the right. There's a little bit of a right beat nystagmus there. Now please look to the left. And there's no nystagmus. Cover your left eye. And then I'm going to see what happens here when I flash the light in front of the right eye. Then she's as though she's in the dark. She's closing the left eye, and we're bleaching the retina with the light in the right eye. So she's in the dark, and we can see there fairly well-defined right beat nystagmus.
So we see the effects of removing visual fixation here. And then there are numerous provocative maneuvers that we may perform in the office to try to elicit nystagmus that we'll discuss later as well. Now, we can't examine nystagmus in isolation. It's important to look at all of the other aspects of a complete ocular motor examination, as well as examine other relevant parts of the neurologic and otologic exam. And as we sought to develop a classification for nystagmus, we considered how this could really be based on several possible attributes. The direction of nystagmus, we could organize it around presumed localization or etiology, or whether the nystagmus was physiologic or pathologic, jerk or pendular, peripheral or central, congenital or acquired. None of those alone would ideally capture the entire breadth of all of the forms of nystagmus that we wish to classify. So we attempted to be as phenomenologic as possible, but also retain conventional nomenclature. And so the way we've organized the classification system is to organize it around physiologic nystagmus first, and then discuss all the pathologic forms of nystagmus and separate those out from other nystagmus-like movements. And for each type, we provide a definition, comments on exam findings, pathophysiology, or other relevant aspects, and then sometimes a list of preferred or non-preferred terms or similar terms. So there are various forms of physiologic nystagmus that are either encountered in day-to-day activities or elicited in a laboratory setting. Physiologic endpoint nystagmus sometimes needs to be differentiated from pathologic gaze-holding nystagmus, which we'll discuss later. But otherwise, these are mostly intuitive to users here, related to rotation, optokinetics, caloric testing, etc. And we won't discuss those further today. As we consider pathologic nystagmus, we divided things up into spontaneous nystagmus, meaning that nystagmus is present, with the patient sitting upright in the straight ahead gaze position. versus gaze-evoked nystagmus, so nystagmus that is seen only related to a change in gaze position, and then nystagmus forms that are triggered by some definable trigger. So if we consider spontaneous nystagmus, we can really be looking at one of three things: spontaneous peripheral vestibular nystagmus, spontaneous central vestibular nystagmus, and then there are some other spontaneous central nystagmus forms that we discuss separately. And spontaneous peripheral vestibular nystagmus could be of the inhibitory type or paretic type nystagmus, or it could be excitatory or irritative nystagmus. And we also can separately describe recovery nystagmus in some circumstances. So, as we consider the horizontal vestibulo-ocular reflex here, by stimulating the horizontal canal on this side, the goal of that system, of course, is to drive eye movements in the opposite direction to try to maintain stable gaze during head movements. And then, of course, if we suddenly lose function on this affected side, we would expect a slow phase eye deviation toward that side and fast phases of nystagmus beating in the other direction. So as we consider spontaneous vestibular nystagmus, the hallmarks of spontaneous jerk nystagmus from an imbalance in vestibular tone, a peripheral vestibular nystagmus, include that the eye movements should be binocular and conjugate in head-referenced coordinates, depending on the canal or canals that are affected, that the nystagmus would beat in a single plane and direction, regardless of the gaze position in that labyrinthine coordinate system, that it would obey Alexander's law, meaning that it becomes increasingly intense the farther that the patient looks into the direction of the fast phases, and gets less intense or may disappear when looking in the slow phase direction, and it would be suppressed by visual fixation, or alternatively enhanced by removing visual fixation. And if we can measure the slow phase velocities, we'd see that they are a constant velocity or sawtooth wave pattern here. We can infer the canal or canals that are affected by looking at the slow phase direction. Here we see what would be expected for the slow phases observed for excitation of individual semicircular canals, such as if we stimulate the left horizontal canal, we develop a rightward slow phase eye movement, as opposed to if we stimulate the left posterior canal, we'd see a combination of a torsional and downward eye movement with fast phases beating in the opposite direction, of course. And something affecting all three semicircular canals would cause a combination of a horizontal and torsional eye movement, slow phases in the opposite direction, with fast phases beating back in the same direction. And of course, if we lose all of our function suddenly on that affected side, we would see the opposite. We'd see slow phases directed toward the side of the lesion. So here's an example of a spontaneous peripheral vestibular nystagmus looking at the effects of visual fixation as well as gaze position. And now, as we place a cover over the goggles, removing visual fixation, the nystagmus becomes much more intense, and we easily see the right beating nystagmus with a small torsional component. It is still right beating in leftward gaze, though less intense, and increases intensity as she looks further to the right. Then, as the cover is removed and visual fixation is allowed, the intensity reduces again. So those are the findings expected to be seen in an acute left unilateral peripheral vestibulopathy. We may see spontaneous nystagmus in other conditions like Meniere's disease, of course, and here's an example recorded from Miriam Welgam-Pola demonstrating here in a patient with right-sided Meniere's disease, the paretic phase or inhibitory phase of nystagmus, where the fast phases are beating away from the affected side, but over hours during the course of an attack, there may ultimately then be recovery of that vestibular function and a recovery nystagmus that then changes direction and beats back toward the affected side that we see here. You can find this and many other videos associated with the classification paper on the ICVD website. So there are a number of forms of spontaneous central vestibular nystagmus to consider, and we divided these up, again, phenomenologically first looking at predominantly horizontal forms of central vestibular nystagmus and then considering vertical and torsional separately, just because the nomenclature and the physiology are a bit different. So we'll first look at direction-fixed horizontal central vestibular nystagmus. This is the form of nystagmus that may be seen in the acute vestibular syndrome and can easily be mistaken for spontaneous peripheral vestibular nystagmus. It's commonly due to brainstem or cerebellar stroke, for example. And so there may be clues that suggest that this is a central and not peripheral problem, because even in the setting of this acute nystagmus, the vestibulo-ocular reflex by head impulse testing may look normal, or there may be other central signs like gaze-evoked nystagmus, skew deviation, impaired vertical pursuit, impaired VOR suppression, or that it's poorly suppressed with visual fixation. It may also sometimes change direction with head shaking or positional changes. But by definition, this form of nystagmus wouldn't change direction spontaneously. There is a form of horizontal central vestibular nystagmus that does change direction spontaneously, and that is periodic alternating nystagmus. This is a conjugate binocular horizontal jerk nystagmus that spontaneously reverses direction about every 90 to 120 seconds. And so we see here, as the patient is sitting in the upright position, that there's a spontaneous right beating nystagmus, but if we continue to observe over the course of 30 and then 60 seconds, that right beating nystagmus slowly resolves and actually becomes a little bit of downbeat nystagmus and a few square wave jerks during this brief null phase before reversing direction and beginning to be a left beating nystagmus. And that left beating nystagmus gradually intensifies as well here. Periodic alternating nystagmus is related to a lesion or dysfunction in the cerebellar nodulus, whether that's by tumor or by stroke or demyelinating lesion, leading to instability of the central vestibular velocity storage mechanism. And we see here in this example now that left beating nystagmus is resolving and it's beginning to reverse to right beating nystagmus again. In this case, this is quite treatable with baclofen. Another form of central vestibular nystagmus that is predominantly horizontal is latent nystagmus, or the fusional maldevelopment nystagmus. And this is a conjugate horizontal jerk nystagmus that's absent during binocular viewing, but it appears with monocular occlusion.
Now just close your right eye.
The fast phases beat away from the covered eye.
Left eye.
And it's associated with amblyopia,
Right eye.
congenital strabismus, and
Open.
Associated vertical
Left
deviation.
eye.
We see here
Open.
that alternating direction. And even if we partially occlude the vision with a Spielman occluder, we see that nystagmus develop
Just keep looking.
binocular horizontal beating away from the covered eye. We also see that vertical deviation under the covered eye. Occasionally, this latent nystagmus is actually manifest, latent nystagmus present with binocular viewing when one eye has poorer vision than the other. If we move towards discussing predominantly vertical or torsional central vestibular nystagmus, the most common form we may see in clinical practice is downbeat nystagmus. This is typically due to vestibulocerebellar dysfunction, like this patient here with rapidly progressive perineoplastic cerebellar degeneration related to breast cancer. We see that there's just a low intensity downbeat nystagmus in the straight ahead gaze position, but as is common, it increases in intensity with lateral gaze. And it may also increase or suppress with convergence, different positioning, like supine positioning, head shaking, or hyperventilation. And then if we move on to other spontaneous central nystagmus forms that are not easily classified or really aren't considered vestibular forms of nystagmus, there are several that I'll discuss a couple of them here. And one is infantile nystagmus. This is a conjugate horizontal nystagmus present from birth or at infancy. And often there are coexisting jerk and pendular waveforms with brief foveation periods, noted here by these arrows. It often increases in lateral gaze and diminishes in a null zone where the patient may have better stability. And this may occur in the setting of other visual sensory disorders or in the setting of normal vision. Acquired pendular nystagmus, like this patient patient with multiple sclerosis, consists entirely of slow phases with no quick phases. And this may have horizontal, vertical, or torsional components. This patient has a somewhat circular or elliptical trajectory to her nystagmus, and the amplitude and phase direction determine that trajectory. Sometimes acquired pendular nystagmus is monocular or dissociated, like we see here, just present in a single eye. With MS, it typically has a higher frequency, at least 4 hertz, and a lower amplitude. But a special form of acquired pendular nystagmus is oculopalatal tremor, and this typically has a large amplitude, pendular eye movements at a low frequency, like 1 to 3 hertz, as we see here in this patient who has had a cavernoma in the pons hemorrhage and damaged the descending central tegmental tract with associated hypertrophic olivary degeneration. We see the synchronous palatal tremor associated with her nystagmus. She's had other facial palsy and Dussen's palsy and required surgery, strabismus surgery on that right eye. So now if we switch entirely from talking about spontaneous nystagmus and move on to talking about gaze-evoked nystagmus, there are a few forms to discuss. We'll focus here on these first couple, recalling that one certainly can see a combination of vestibular nystagmus plus gaze-holding nystagmus in things like a cerebellopontine angle tumor, referred to as Brun's nystagmus, but I'll mention some of these others here next. Now, gaze-holding nystagmus is commonly related to dysfunction in the cerebellum just because of its importance, the vestibular cerebellum, in the pathways that help improve function of the neural integrator. And so here's a patient with an autoimmune cerebellar ataxia demonstrating prominent bilateral gaze-holding nystagmus as well as rebound nystagmus.
Now
and so this
head still.
impaired gaze-holding
Watch the
function
light over to the side here.
is related to those
Now a little bit farther
pathways
over.
that
Good.
support the neural integrator that would normally
Looking there, you're
keep
doing
the
good.
eyes stable in eccentric gaze. We see after sustained eccentric gaze, when she looks back
Now you
to
can look back at my nose.
the middle, she has a brief, what appears to be spontaneous nystagmus beating in the opposite direction.
Now
We
look over.
refer to
Can you
that as
see
rebound
to the left
nystagmus.
there?
Yeah.
It's typically associated with
Right on the light.
gaze-holding nystagmus and often seen in cerebellar
Now
dysfunction.
look back at my nose one more time.
We see that briefly beating in the other direction. Sometimes it's challenging to differentiate a gaze-holding nystagmus from first-degree vestibular nystagmus. In other words, peripheral vestibular nystagmus seen only in a single eccentric gaze position. This is the previous patient I showed you with the acute unilateral left peripheral vestibulopathy. 8 weeks later, we see only a slight right-beating nystagmus in rightward gaze. The eyes are quite stable in straight-ahead gaze and leftward gaze during visual fixation. But in rightward gaze, she has just a little bit of gaze-evoked nystagmus. So we would call that first-degree vestibular nystagmus because it's present only in looking in the direction of the fast phases. But if we remove visual fixation from video iconography, we still see that there is a little bit of spontaneous
Normalize it. Now we'll put these back on.
nystagmus. Here we put the goggles, the cover on, and we bring out a little bit of right-beating nystagmus and straight-ahead gaze. Okay. And now if we move from gaze-evoked nystagmus to triggered nystagmus, there are many potential triggers for nystagmus. In clinical practice, we are most often interested in positional nystagmus related to BPPV or sometimes other forms of positional nystagmus, and things like Valsalva pressure or or sound-induced nystagmus and superior canal dehiscence, but there are a number of other ways that we can provoke or trigger nystagmus as part of the examination that can be informative. I think in the interest of time, I won't show this video showing classic left posterior canal benign paracipal positional vertigo nystagmus, since most of us are familiar with that, but we'll of course mention that in clinical practice, if we're suspicious of BPPV and the Dix-Hallpike is negative, it's important to look for horizontal canal BPPV with the supine roll test. But indeed, there are forms of positional nystagmus that are central and not due to canalolithiasis. And this case just illustrates someone with cerebellar degeneration who has a little bit of spontaneous downbeat nystagmus in the upright position, but then develops more prominent positional nystagmus. So, you ready? Let me just get a comparison here. All right, you ready? Let's just lay back, just like that. And are you having any symptoms right now?
No.
Are you okay? I'm just going to have you rotate your head like that. See if that. Now just keep looking straight out the middle of the goggles, though. So she has more intense downbeat nystagmus, but in the right supine roll test begins to develop some left beating or apogeotropic nystagmus as well. It's really not symptomatic, though. She's not experiencing vertigo, despite. We're getting a little bit of left beating with right ear down, aren't we? You doing okay? You feel just fine lying here, don't you? And let's just bring your head back up. Now, if we roll your head to the left, left ear down. Yeah, then it reverses. But again, you feel okay.
I feel all right. I can't make them sit still.
So you can feel the fact that the eyes are moving.
Yeah.
But it's not making you feel like your whole world is spinning upside down.
No.
Another important triggered form of nystagmus is Valsalva-induced nystagmus and superior canal dehiscence syndrome. And in this case, this patient has both glottal Valsalva and nose pinch Valsalva-induced nystagmus. Big breath in, eyes wide open, and then bear down as hard as you can. And then release it. I'm going to have you pinch your nostrils closed tightly with your fingers so no air can get through your nose. Then take a deep breath in through your mouth and try to blow out through your pinched nostrils like you're going to clear your ears. You feel the pressure in the ears. You ready? Eyes wide open. Big breath in. And now just put some pressure in. And then release it. Eyes open? Eyes open? Yeah. Okay. Oh, I got you here, but you can hold on there. Yeah. This patient actually also had some positional nystagmus, a little bit in the Dix-Hallpike position, but in particular, upon sitting back up, developed a prominent nystagmus, likely related to shifts in the intracranial pressure with those position changes, putting different pressure within onto the semicircular canal through that dehiscence. And then here's another example of several other different forms of triggered nystagmus in a single patient who did not have complaints of vertigo, but rather slowly progressive unsteadiness associated with a left sensorineural hearing loss, which proved to be due to a left vestibular schwannoma. We see with vibration and head shaking, he develops right beating nystagmus. And here's the right ear. An inhibitory type nystagmus related to reduced function on the left. You can help me here. We're just going to move your head back and forth, just kind of shaking the head side to side several times. All right, now we'll stop. Now, can you do some of that really deep, fast breathing? Do it just as well as you did a moment ago. Ready? Might make you a little lightheaded, but
Try to do 10 really big fast ones if you can. Blow out all the air.
So now we see he's developing left beating nystagmus, beating toward the
All right,
side
now you
of
can
the
stop
lesion
and rest, just keeping your eyes open.
with hyperventilation, essentially inducing a recovery nystagmus with transient improvement in the conduction through this nerve during the course of hyperventilation compared to what the brain has become accustomed to. Okay, so let's move entirely from nystagmus and discuss other nystagmus-like movements, beginning with saccadic intrusions and oscillations, and then we'll discuss a few other nystagmus-like movements. So saccadic intrusions and oscillations refer to the situation where it's a saccade that takes the eye away from the target. And one example here is ocular flutter, which refers to intermittent bursts of conjugate horizontal saccades without any intersaccadic interval. Back-to-back saccades, unlike square wave jerks, where there's a momentary pause before the eye returns to its original position. And like opsoclonus, which is multidirectional, ocular flutter is similarly associated with para-infectious and paraneoplastic encephalitis, like this teenager with a post-infectious cereballitis. Sometimes saccadic intrusions can present quite a diagnostic challenge when they are ultimately related to a functional disorder. And functional saccadic intrusions, or what has previously been called psychogenic nystagmus, when presenting with symptoms can be challenging, such as in this patient.
Let your eyes relax while it develops.
Yeah.
She said that if she wasn't consciously willing herself to keep her eyes steady, they would begin to oscillate like this. But then she could take control of it.
All right, now it's going, but make it stop.
And get her eyes to stabilize.
All right, now you can let it start again.
So some people, of course, can do this as a party trick at will, but if it's not exactly
While
voluntary,
it's going, can you look up here at my finger?
it can be challenging. Oftentimes, distinguishing features from ocular flutter include that usually it's difficult for people to sustain this indefinitely. It's often accompanied by convergence effort or facial grimacing or eyelid flutter, as we see here, whereas pathologic flutter and opsoclonus are more sustained, irrespective of the patient's vergent state. And then I'll mention just one of the several types of nystagmus-like movements here, superior oblique myokymia. This does not typically cause sensation of vertigo, but patients instead describe brief intermittent bouts of monocular oscillopsia. This is related to intermittent contraction of the superior oblique muscle, which moves the eye in a downward and intorsional direction when it contracts. And so here we see, this is actually a patient that was sent to our vestibular laboratory, and this was captured on VOG, and I was able to actually make that diagnosis without seeing the patient. And here we see these little brief bursts of intorsion and downward eye movement in that single eye. So this is not a vestibular nystagmus. Most often, this is attributed to a microvascular compression of the trochlear nerve, as can sometimes be demonstrated. Here's a case in the literature demonstrating that the superior cerebellar artery compressing the trochlear nerve. This is a treatable condition as well, typically with medications like carbamazepine. I'll mention only on this slide here that, although this was not any focus of the paper, we should be aware of many treatments for different forms of nystagmus. So in addition to really wanting to evaluate and appropriately classify and diagnose the nystagmus form to lead the diagnostic workup, some of these specific forms can be quite treatable with the appropriate medication. So in summary, when characterizing nystagmus, it's important to describe the eye movements from the subject's vantage point, including torsional eye movements. Choose a reference frame to help you decide whether the eyes are obeying a trajectory that aligns best with the semicircular canals or with the visual axis or otherwise. And remember to take note of and document a variety of attributes, including binocularity, conjugacy, the waveform, estimated velocity or frequency, or the intensity, the temporal profile of the nystagmus or overall condition, and the effects in different gaze positions and with and without visual fixation. And then you can begin classifying that nystagmus into whether it is either spontaneous, gaze evoked, or only triggered by specific triggers, and that can help lead you to evaluate based on that nystagmus type and use pharmacologic treatment for some forms of nystagmus. Thank you for your attention. We will take questions during the live Q&A.
Thank you. I'm online again, I think. Yes, I hope so. Well, thank you, Scott, for your nice presentation and the nice illustrations in this quite complicated area where we all take a long time to get enough experience to look at that. I followed the chat, and I think it was mostly filled with problems of getting connected, so there were no questions. So I will ask you questions about the relationship between nystagmus and symptoms, because we don't have much of a conscious experience of our eye movements, don't we? So what kind of, does nystagmus make symptoms, or does a disease which makes the nystagmus also make the symptoms? Or how would you comment on the relationship between symptoms and nystagmus?
Yeah, that's an excellent question. And thanks for the opportunity to present our work. As I demonstrated with the patient with positional nystagmus on the video there's certainly sometimes a discrepancy between the intensity of the nystagmus and the presence or intensity of symptoms. And I think it can go either direction. Of course, we see patients that have a vestibular nystagmus who sometimes have very little in the way of symptoms. We also see the opposite, where we have difficulty appreciating much nystagmus in patients that really experience tremendous vertigo. Sometimes that's because of the way we're examining them and we haven't removed visual fixation, for example. But I think that can give us a diagnostic clue sometimes if there is a great discrepancy between the observable degree of nystagmus and the presence or intensity of the symptoms. If there's a significant mismatch, that sometimes seems to be a clue that we may not be dealing with a peripheral vestibular disorder. And in particular, I think with positional vertigo, when we see strong nystagmus in the absence of any symptoms, that's less typical for BPPV. And I think the opposite is sometimes true as well. Again, provided that we are certain that we're actually taking steps to be able to observe any nystagmus that's present. Sometimes patients experience more of the illusion of visual motion, the oscillopsia aspect of it, without as much of a real sense of internal motion or spinning. And I know that this committee has considered or kind of reconsidering how to name or describe those symptoms and exactly what external vertigo, versus oscillopsia should mean, and are they one and the same always?
Yeah, but you didn't comment now on the possible difference between the symptoms generated by a jerk nystagmus as opposed to a flutter or a pendular nystagmus.
Right. So, typically the primary symptom with pendular nystagmus is severely impaired visual acuity due to constant oscillopsia. So patients with pendular nystagmus, there's never a period of time during which the eye is stable to really be able to get a good glimpse of the world. So because there's constant retinal motion slip, the world is constantly in motion for them, and this severely degrades our visual acuity. And so they really have significant visual symptoms.
Mm. Yeah, that's also my experience, that the part of the pendular ones, the other ones are often very, very poor in symptoms. And so it is really something you need to pick up on a targeted examination rather than on history taking. That is, although history taking is so important in our vestibular workup, for nystagmus, it is really the examination which matters.
Yes.
Okay. Well, I haven't seen any more questions. Then I have maybe another question about the, do you have any good tip to give if people do too many blinks during examination?
Do I have any good tips for how to get people to stop blinking?
Yeah.
I'm not sure that I truly do. Do you have any good tips? I would be happy to hear them.
I must say that we are, we tend to examine people under goggles, but goggles prevent you from opening the eyes with your fingers. And if you provoke a vertigo and a nystagmus by lying somebody down, for example, and they close their eyes exactly at that very moment, then we might have missed the most important moment.
Yes,
that's
certainly true.
I am often hesitating to use goggles systematically when I want to provoke a positional vertigo, simply because of that reason.
Yes, I think in terms of using goggles or looking for positional nystagmus in that example, one thing I will do is usually prepare them in advance by telling them what they might experience. And even if they feel things spinning, that I want them to keep their eyes open because that's how I'm going to be able to examine and diagnose them, and that I'm not going to let them fall off the table, and do those preparatory things so that they're consciously thinking about keeping their eyes open. And it sometimes helps to remove the cover on the goggles, because if they can actually be fixating a target, even though it might hamper my examination a little bit, it might make it easier for them to keep their eyes open. When they're in absolute darkness, they sometimes have a difficult time even knowing that their eyes were closed in the first place.
Yeah. We got a comment here. For blinking, Dr. Z taught me to examine with the lids gently closed and oblique light to see the shape of the cornea moving under the lids. Oh,
absolutely. That's coming. That's a comment coming from one of my doppelgangers here. It looks like, who have logged in under my name. Must be John Perry.
Will the real Scott Eggers please stand up? Sorry, we had to sneak in with your link.
Okay.
John, yeah. Do you want to elaborate on that, John?
Hello, John Kerry. Yeah.
Hi, everybody. Yes. So sometimes it's helpful to have the patient just gently close their lids. I don't know if you can see this, and sometimes you can see the.
You're looking at the limbus, the cornea. You're looking at the cornea move under the lid. Is that what you're saying? Yeah.
Scott, I have one other question, if I may.
Sure.
Please.
You said that amplitude is often not very helpful by itself. I just wonder about the example of Brunn's nystagmus and the amplitude changes we see with Brunn's nystagmus.
So are you referring to, what might be a sort of a lower amplitude or a fine kind of nystagmus when looking in the, essentially the vestibular nystagmus in one gaze direction is fine, and in the cerebellar direction is more of a coarse or high amplitude nystagmus? Yeah, no, that's an excellent point. I guess the point I was making is, if we look at a typical vestibular nystagmus, the amplitude alone, the size and degrees of a single beat, if considered in isolation and not along with the slow phase velocity, is usually by itself not too helpful. But that's an excellent example of a combined peripheral and gaze holding nystagmus, where they typically, even at the bedside, you may be able to appreciate that difference just because of the amplitude of each beat is typically smaller in one gaze direction.
Well, speaking on behalf of Scott Eggers, I just want to say that was a great presentation. The society needs more of you, and fortunately, we can do it easily here in Zoom.
It looks like we're replicating me as we speak, so I appreciate that.
Okay,
Thanks
but
for
if you
joining.
give the if you give the suggestion that you can observe the eye move under the eyelid, do you also sometimes use your finger to palpate nystagmus? Do you use that sometimes? I do sometimes.
Yeah.
When people are very dizzy and they don't want to open their eyes, you can actually also feel the nystagmus, at least the lateral one.
Absolutely, you may be able to see it or feel it, and I'm recalling, I think it was an oculopalatal tremor case that Dave Z and colleagues published a few years ago, where it was much more prominent with eyes closed. I think it was absent with eyes open, and you could clearly see the cornea moving under the closed eyelids.
Okay, well, we are a little bit ahead of schedule if there are no further questions, but then we could actually move on, I think, to the next presentation, which it will be about mal de débarquement syndrome. If the operators on the background are ready or getting ready to play it up. So that gives me the opportunity to introduce the speaker who has arrived, as far as I can see. So it is an honor to introduce Yoon-Hee Cha, who is. I still see Scott Eggers on the main screen. I don't know if I should see now. Yoon-Hee, hello. Yes, I see you. Can you unmute yourself and speak so we see that you're coming up?
Hi, everyone.
Hi, Yoon-Hee. Okay, good. So Dr. Yoon-Hee Cha is Associate Professor of Neurology at the University of Minnesota in the United States. And she's a neurologist who has studied and is studying motion perception with neuroimaging and neuromodulation and functional imaging. Her practice involves caring for patients with neurological disorders and well as headaches. And she has taken on board actually two quite complicated topics for our definitions, which is mal de débarquement syndrome she's going to present today. And tomorrow she's going to present to us motion sickness. So we are looking forward to your presentation. So again, it is pre-recorded and she will be available for questions afterwards.
Hi, I am Yoon-Hee Cha. I am a neurologist from the University of Minnesota, and I will be presenting on the diagnostic criteria for mal de Debarquement syndrome. So thank you for the opportunity to share the work that the classification committee has done on mal de Debarquement syndrome over the several years. As the chairperson of that committee, I have the privilege of presenting these criteria on behalf of the subcommittee. The committee had 8 members, including myself. Our subcommittee included representatives from neurology, otorhinolaryngology, physics, and psychiatry, hailing from 3 continents. A decision to create the subcommittee happened in March of 2017, originally envisioned to be done as a single paper with motion sickness, and then subsequently divided into 2 papers. Subcommittee selection was completed by June 2018. The paper drafted shortly thereafter, sent to the classification committee in June 2019, revised and then presented to the Greater Bárány Society membership in January 2020. After some revisions, we submitted the paper to the Journal of Vestibular Research later that year, which was printed in its final form in December 2020. Now, mal de Debarquement syndrome, you may know, is somewhat of a counterpoint to mal de mer, which is sickness of the sea. And tomorrow I will present the criteria for motion sickness. Motion sickness is the sick feeling you get while you are out at sea, whereas mal de Debarquement is what you experience when you come back to land and continue to feel like as if you were out at sea, as if you were still on the boat. So it is the sickness of landing. So here are the criteria. MdDS is characterized by a persistent non-spinning vertigo that is experienced as an oscillatory sensation that is present continuously or for most of the day. The symptoms start within 48 hours after the end of exposure to passive motion, typically water, but can be air or land. Symptoms temporarily reduce with exposure to passive motion, such as driving a car or rocking in a rocking chair, although they are often worse once the motion stops. And the symptoms continue for more than 48 hours. And this criteria we place in order to separate it from land sickness. We divided the duration of MdDS into 3 categories. If the patient presents within 1 month of symptoms, but there hasn't been at least 1 month of observation time, we consider that MdDS in evolution, since we don't know whether it will go away on its own. If the symptoms last for less than 1 month and the symptoms have resolved within that 1 month, it is diagnosed as transient MdDS. And of course, transient MdDS can only be diagnosed in retrospect. The clinically significant form of MdDS is when it lasts for more than 1 month, and this is considered persistent MdDS. And as with all Bárány criteria, the symptoms cannot be better accounted for by another disease or disorder. We call the symptom of MdDS as a form of non-spinning vertigo because it is indeed an illusion of motion. The motion, however, is experienced as a form of oscillation, typically described as a rocking, bobbing, or swaying. Patients will say that they feel like they are on a boat. Now, the term oscillatory here is used to describe the feeling of the vertigo, not that the vertigo comes and goes. This oscillatory vertigo of MdDS is actually fairly persistent. And to be more precise, we defined rocking as a fore-aft perception, bobbing as an up and down perception, and swaying as a side-to-side perception. This can be helpful at times, but it is also quite frequent that the perceptions can be mixed and even change with time. Some patients are able to say that they experience a very specific frequency of motion perception and can even time it out. There is usually a superimposed feeling of gravitational force, such as being pushed or pulled in one direction. Under the International Classification of Vestibular Disorders scheme, MdDS would be considered a form of internal vertigo, as the feeling is experienced as self-motion rather than environmental motion. The ICVD included a code for other triggered vertigo that occurs after prolonged exposure to passive motion, as occurs following sea voyages, and this is where MdDS would fit. Now, a dimension of MdDS that is not captured in current ICVD terminology relates to the haptic or somatic perception of the environment in motion. So for example, the ground undulating or feeling like you're rocking on a boat. So this is the sense that the environment is acting on the person. Since it is not perceived as a visual phenomenon, it would not fit the definition of external vertigo. And complicating this perception is that sometimes the patients can say that they are moving and sometimes that they are being moved. In other words, the reference point for the source of the motion can be fluid. And we don't know what causes that, however. There are some interesting features of MdDS. In our neurootology clinic at UCLA, before we started to publicize MdDS research studies, MdDS patients made up about 1.3% of our clinic patients and predominantly made up of women with a peak age of onset in the 40s to 50s. Here is the data in a little bit more detail. The female to male ratio was about 4:1. Median and mean age of onset was in the mid-40s. And since we were a tertiary care center, the median duration of symptoms was already at 12 months before the patients had presented. The most common trigger for symptoms was water travel, followed by air, followed by land. What's quite interesting about this disorder is that it's a disorder largely of the middle age, with a peak age of onset of the first lifetime episode of persistent MdDS occurring between 40 to 50 years with a bell-shaped curve. This graph shows the age of the first and the last episode of MdDS lasting at least 1 month. About 34% of individuals who had developed MdDS had concurrent menopausal symptoms at the onset, and 57% were technically postmenopausal. And this data is based on 80 individuals. There are a variety of associated symptoms with MdDS, such as a sense of dizziness or disorientation, cognitive slowing, casually referred to as brain fog, fatigue, which can be quite severe, hypersensitivities to light and sound, headache, which can be new or worsening of existing headache, and the emergence of anxiety. These occur to varying degrees in each individual, and their presence does not add diagnostic accuracy given their nonspecific nature. The differential diagnosis of MdDS mainly includes vestibular migraine, persistent postural perceptual dizziness or PPPD, and motion sickness. The main features that distinguish MdDS from vestibular migraine is that the latter is an episodic disorder with a limited duration of vestibular symptoms, whereas MdDS is a chronic syndrome from the start. Vestibular migraine also requires a personal history of migraine headaches, whereas at best, about 46% of people with MdDS will meet criteria for migraine based on head pain and hypersensitivity. However, a history of episodic migraine headaches in MdDS before the onset of MdDS is only seen in about a quarter of patients with MdDS. Therefore, MdDS is not simply a manifestation of vestibular migraine. There is more overlap with persistent postural perceptual dizziness, or PPPD, which is defined as a chronic disorder of dizziness, unsteadiness, or non-spinning vertigo, which can be a swaying or a rocking sensation in some patients. These symptoms are worse in the upright position and are worse with either active or passive motion, and by definition are worse by visual stimulation. Of these three characteristics, MdDS symptoms overlap with two, being worse in the upright position and being worse with visual stimulation, which occurs in about 2/3 of patients. MdDS patients, however, feel better when they are back in motion, whether passively or actively moving. People with MdDS will often say that they actually feel better when they're walking briskly or playing a sport. Another main difference with PPPD is that PPPD can be triggered by many different homeostatic perturbations, but is not triggered by motion. Finally, is MdDS a form of motion sickness? Well, actually, in some ways, they might be the opposite. People with MdDS like to be in motion. As we'll cover tomorrow, motion sickness is triggered during the exposure to motion and is typified by nausea and or gastrointestinal disturbance, thermoregulatory disruption, alterations in arousal, some dizziness or vertigo, headache and or ocular strain, with the symptoms happening during the motion and stopping when the motion stops. People with MdDS feel fine while in motion and only have symptoms when the motion ends. The one dilemma that we faced was that what about these patients who have some characteristics of MdDS and some characteristics of PPPD? This is a picture of table 1 from the paper. So these are patients who present with persistent oscillating vertigo that generally develops over days to weeks from non-motion triggers. Now they can feel unsteady and may have sensitivity to visual stimulation. Unsteadiness and visual sensitivity are defining features of PPPD, but they may happen in MdDS. Now, these patients in the overlap syndrome are not triggered from motion, but they do feel better when they are back in motion, like driving in a car. Interestingly, all three groups of patients respond to antidepressants that act on the serotonin system. These patients are descriptively called non-motion triggered, motion moderated, oscillating vertigo. Now that is a mouthful, and we did go through a number of different names listed here, and no two people on the committee like the same name. I personally like number 3 and number 4 because the acronyms spell MOVIN and I move, which is how the patients feel. But at the end of the day, we didn't have enough data to support classifying this disorder into any particular category. Therefore, we did suggest some ways to determine which category this overlap disorder falls under. Is it more like MdDS or more like PPPD? Or is it in a category of its own? So these studies could include a detailed interrogation of clinical features, gait analysis, posture testing, looking at associated syndromes, defining by treatment response, and perhaps evaluating through imaging studies. And some of these studies are already underway. For now, we hope that these criteria will provide a useful starting point for making the diagnosis of MdDS for both clinical purposes and research studies. These criteria on MdDS syndrome are the first to be presented to encourage recognition of MdDS syndrome as an important neurootological syndrome with often high morbidity, and to help establish some standardization in diagnosis. So on behalf of the subcommittee for MdDS syndrome criteria for the Bárány Society, I thank you for your attention. And at this time, I'd be happy to take any questions.
Thank you very much, Yoon-Hee. Excellent presentation. Unfortunately, I cannot really applaud, or nobody can. That is the disadvantage of having the meetings online. I I don't see any questions in the chat room. Let me ask you about, maybe you can, well, I think you did go into it to some extent, but maybe you can comment again on which were the most difficult issues you had to resolve in your subcommittee in the definition of MdDS syndrome.
Can everyone hear me first of all? Yeah. Okay, great. So first, let me start by saying we had a really excellent subcommittee, and everyone just worked incredibly well together. So it was really a privilege for me to be able to work with this group of people, and I certainly learned a lot from all the discussions. The criteria themselves, for kind of classical MdDS syndrome, I think came relatively, in a straightforward manner. What we really struggled with was the group that looks just like MdDS, right? Where the patients present with the chronic feeling of motion, and if you didn't have the historical feature of being triggered by motion, they would look really, really similar. And what we know is that this group of individuals who have the non-motion triggered symptoms, they've gone by all kinds of names, spontaneous MdDS or atypical MdDS or non-motion triggered MdDS, and they kind of feel the same, in a lot of ways, but they also have less response to treatment. And so really, I would say probably half our discussions involved, is this also a form of MdDS? And so I would say that was probably the toughest thing that we dealt with. And I think we dealt with it hopefully, correctly, and to be somewhat agnostic, about what this syndrome is. And there may be more underlying that perception than what we have been paying attention to until this time.
Okay, thank you. So we got now a few questions in. Maybe I go just from top to bottom. So the first one I see here, I'll just read it to you. Do you consider this a functional disorder or a branch of functional neuroautology?
Oh, so I think we have to kind of define and agree upon what the word functional means, right? So, and depending on what sort of generation of training you're in, you might think of functional as being more along the lines of what we used to call psychogenic, right? That this is, kind of primarily a disorder that should be categorized with somatoform disorders and disorders that emanate from underlying unresolved conflicts and anxiety, et cetera. And I think kind of the definition that we're kind of moving towards, which actually kind of goes back to more the original definition of the word, functional, going, back to the 19th century, is that the symptoms arise from an actual dysfunction, like the organ is actually being dysfunctional, right? And so without the other kind of layer of this is primarily driven by psychic problems. So from that standpoint, I would say that MdDS, like PPPD, is a functional neurological disorder. We never see vestibular, peripheral vestibular abnormalities. We don't see brain injury in a way that we can measure it, with current clinical imaging tools. We do see evidence of abnormal functional connectivity, right? We do see evidence of alterations in the amount of synchronization between different parts of the brain. From that standpoint, I would say that it is a functional disorder.
Thank you. That was a very nice and clear answer. I have a question before I go to the next one from the chat room. In triple PD is a complication of many vestibular disorders, as you mentioned well. But we also know that if you have a vestibular episode or vestibular episodes in which you are terrified, very anxious, that increases the risk of developing triple PD. Is something similar observed for MdDS?
So that's an interesting question, and we do face this sometimes. Does the patient have, MdDS plus PPPD, or do they have MdDS plus maybe like an adjustment disorder, just like the way that you might have, any other kind of neurological insults, and then is there a layer on top of that, right? That has to do with just the reaction, to that process. At the end of the day, I don't, people are not like, we're not like Legos, right? You can't just put like a layer that's very well defined and then put another layer that's very well defined, where, I don't know that we can quantify it that, that way. So at the end of the day, I really don't know. I do think that there is, both with MdDS and with PPPD, there is a therapeutic strategy, I would say, that is very helpful, to patients. One is to affirm that their diagnosis is real, right? And we recognize this as an actual brain dysfunction, and to also help them to understand, like, this is how the brain works, and there are certain tools that you can use that can help mitigate the symptoms, right? So that help the person have more control over their symptoms. And so from that standpoint, I do think that the psychological layer of it, I think, is actually very important. And as we know with PPPD, cognitive behavioral therapy can be really helpful. I haven't seen it as helpful with MdDS. I know a lot of our patients do use psychological services, and I actually encourage it in certain patients. But I guess my standpoint is more on the education end of it, to just help the patient say, here are some components, here are some things that we know will make things better or worse, and we'll just bring some tools to you, that can be helpful.
Okay, I think we get a lot of questions coming in now. One you might have already answered, coming from John Waterston from Australia, is if you have seen triple PD as a complication of MdDS syndrome.
Yeah, well, so that's yeah. So I think that was the. It's kind of hard to know, like, what is the how much of their symptoms do you attribute to MdDS versus PPPD? And so one of the things I learned working with the committee. First of all, it is really quite a privilege to work with people who've thought about these disorders for a very long time, longer than I have, but to see the process of how criteria are created, right? I mean, they're created, based on the current understanding of how to best logically group these symptoms, and so as I mentioned, 2 out of the 3 symptoms of PPPD, we also see in MdDS. And so, whether you draw a circle here and a circle here, and decide how much of it overlaps at the end of the day, it is somewhat subjective, but it's what we can do the best right now with the data that we have right now, right? And so I do think the imaging studies can also be really helpful to us, and help sort of sort out this thing that we're calling PPPD, how different is it from this thing that we're calling MdDS, and so I think some of those studies, which have been done separately until now, I think it'd be really useful to be able to do them together.
Okay, thank you. So the short question maybe is, how are people with migraine more susceptible to MdDS?
Overall, I don't think so. I mean, with the kind of typical motion triggered MdDS, and I would say that I was even surprised by this when we looked at, prior to the onset of MdDS, how frequently, did the person have a history of migraine, and it, I was sort of expecting it to be very high, but it actually turned out to not be. But what does happen is that when they get their MdDS symptoms, their underlying migraine can get worse, and they can also develop new onset headache. Now, one of the headache types that people get with MdDS, it can kind of technically be diagnosed as migraine in that they have kind of a moderately severe headache, with associated light and sound sensitivity, and nausea. I'll say that the headache that people get with MdDS is often more persistent, and it's often described as a lot of head pressure rather than, like unilateral, like throbbing headache. And so I think looking at what might be happening in those patients, right? And how is that similar or different from episodic migraine? I think that's really worth looking into. For example, we're looking into vascular abnormalities in people who develop migraine with Meniere's disease. Now, this other group, though, that has this, kind of non-motion triggered feeling of oscillation, right, of this movement that looks very similar to MdDS, those people do have a higher background rate of migraine, and so there's definitely overlap. Whatever migraine physiology is, it's definitely related to this feeling of oscillation, or in some cases, it might even be a feeling of like a pulsation.
So not a simple answer, complex mutual connections, as far as I understand. So there are many questions on treatment. So maybe you can group them a little bit. There are questions about what you mentioned it a bit of mental behavioral health perspective, support to give, what do you use as drugs and what else do you use as drugs? What are the tools of mitigation? What are trends of new treatments? So plenty of questions of what is there and what will come.
Yeah, so yeah, really, really great questions. And I try to remind people, we're only in 2021, right? So we don't have all the answers to these issues yet. And I try to remind, patients, also that we're basically like a point on a line, and we want the next point to be a little higher. Some things can make the slope of that line, more shallow and more, and steeper. But I think, from the mental health point, I think really the most important thing is to give validation to the patient, right? Because a lot of these patients have been told for many years that the problem is essentially because they're an anxious person, and all your studies are normal, and so nothing could possibly be wrong with your brain, and the problem is that you're just too sensitive, and you're overthinking it. And so I think this is where the criteria is really, really important, and really a service to the patients to say, this is a serious problem, and this is, and many people have had this kind of feeling before, right? I mean, I've personally had the post-motion rocking for up to a week. It was severe enough. I mean, at that point, I thought my career would be over. But just imagine, living like that for months or years. And so just giving them that affirmation, like your symptoms are real. We take it seriously. The international criteria, for the Bárány Society, they know that this is a real disorder. So that goes a long way. I also educate the patient on like what we're working on too. Say this is here are the treatments that we have right now, but we're also working on some other things. That is really helpful. I am very open and to working with psychotherapists and psychiatrists, and so if there's someone that they have a connection with, I love communicating with other care providers, because a lot of times they won't know what this disorder is, right? I mean, it could be, some unusual cancer as far as they're concerned, and so working with the other care provider is really important. And by and large, I'll say that it's taken really well, and people find MdDS to be really fascinating, and so. So that's kind of fun for me too, is to see enthusiasm, on the other end.
Do you see a perspective for neuromodulation techniques?
Yes, and so drugs, treatments, and what do I use? So we've done neuromodulation studies, using both two forms of TMS, so just the standard 10 hertz dorsolateral prefrontal cortex TMS that's used in the treatment of depression and anxiety. We've tried that. And also try theta burst stimulation, which is a more rapid form of stimulation in which you give 50 hertz stimulation in 5 hertz intervals, which is where the word theta comes from, is the 5 hertz part of it. And so those targets were in the midline cerebellum and in the occipital cortex. And then we've done studies with both transcranial direct current stimulation and transcranial alternating current stimulation. And so what's been good is I think they've become more and more effective. In fact, the earliest studies that I did with the dorsolateral prefrontal cortex study, stimulation, that was actually the least effective protocol. And so I'm somewhat surprised that my career survived that early period for us to get to this next stage. The challenge with MdDS is access, because here's a disorder in which it's triggered by travel, right? And so if the therapy is not available to the person within a short, drive, I mean, how are they going to access it, right? I mean, they'll just risk re-triggering their symptoms all the time. So one of the things that we're working on right now is how do you safely provide treatment remotely. And so right now we're working on one of those tools with transcranial alternating current stimulation.
Oh, yeah. Interesting perspectives. There is a question here on prognosis of treatments. The question is, what is your clinical experience in treatment response to MdDS versus triple PD?
For prognosis? So, well, it's kind of tough, right? Because MdDS, we haven't been working on MdDS for very long, so we're kind of at the starting line, point really, right, to even have criteria to make this diagnosis. So, just like with a lot of disorders, the longer that you have it, the longer that you have it, right? And so this is our challenge is, what can we do for the people with MdDS who present before 6 months, right? Because it seems that once they get past about 6 months, the probability of, getting better on their own, or just with kind of clinically available treatments, it starts to go down, like a slope that, like this, right? So that's where we are. And so so it's important that you use all the tools that you do have. Don't waste any tools that you have, right? And so, we've known for a while now that long-acting benzodiazepines and drugs that act on the serotonin system are helpful in MdDS. There's a little bit of art to using these medications. If anyone's interested, I mean, I can go into the details of that, but I'll just kind of leave it at that those are the two classes of drugs. And you can use them together. Sleep is very important. I always tell people, like, your sleep is, unless like a pilot who lives in the house, I said your sleep is the most important, in the family. We're also looking at potential vascular, like a component or a myofascial component, to MdDS, and hopefully we can maybe bring some other types of modality-based treatments. But during that time, I think people do need a lot of support. Over time, for whatever reason, people do tend to get better. They do tend to either adapt to the feeling or bring more tools in. But whether MdDS is more treatable than PPPD, that I do not know. That part I don't know.
So that's still an open question. I think there's a question about, is there a place for virtual reality in the therapy?
Ooh, interesting question. I have not thought that much about it. One thing is I personally get very sick with visual motion. And so and all the therapies, by the way, that I've had my participants do in our research studies, they're all done on me first, and they're all titrated on me. So I've had a lot of TMS on my head and a lot of transcranial alternating and direct current stimulation on my head and on my face and on my vestibular, everything. So, I can see it being kind of intriguing. The one thing I'll say is that I don't see a really good mechanism for using virtual reality right now. But I think there could be something there, not necessarily just with motion, but one of the things that we saw with our transcranial alternating current study is that as people got better, one thing that we saw is that the amount of synchrony between the frontal parietal attention network, that synchronization went down. So, I mean, you could maybe theorize that there might be some kind of a VR stimulation that might do some kind of brain desynchronization. I have to babysit the dog while I'm doing this, so I just let her out. Yeah, so there might be a way if there were people who were really interested and knowledgeable about doing visual therapies for other disorders. They might want to talk about that at some point.
But my understanding is that MdDS is triggered by an exposure to actual motion. It has not been triggered by exposure to purely visual motion, or has it?
So there has not been a really solid report that this has happened. I mean, there is this one reference that was kind of floating in the literature that unfortunately was one of these, it got a little bit kind of overstated in one paper, then it got kind of copied into another paper, and then it got copied into review. And so this is one of these situations where it's really important that you go back to the original paper and see what they really did. And so, so there was this reference of people giving VR stimulation and how they had felt a bit dizzy after they were given this VR stimulation that lasted less than 25 minutes. And then somehow like that paper got into these MdDS papers. And so it might happen. I just don't, I haven't seen a clear report of this where, for example, someone's playing a video game for an hour and they have this persistent feeling, going on for more than 48 hours. By the way, if anyone out there has had a patient in which this has happened, please let me know, because I think it is very interesting.
Mm-hmm. There are comments in the chat room about the DICE protocol, which is a combination of optokinetic and vestibular stimulation to reduce the velocity storage, isn't it?
Yeah. Also, so with the VOR readaptation study that was pioneered at the Mount Sinai group. I mean, yes, you can use VR goggles to give optokinetic stimulation, with the head rocking. I was thinking that it was actually more where the VR, like the component of the VR stimulation, whether it's a game, or something, or the kind of motion was the actual treatment. But VR itself has been used, I think, fairly commonly now for all kinds of like vestibular rehab, right? So.
Okay. I think we had a lively discussion. I don't see any new questions anymore. So the bottom line, it is still a relatively newly recognized entity, which eventually gets its merit, and the proper definition allows us also to conduct better the research on its causes and how to treat it in the future, and already now, obviously. So I think that if that is like this, thank you so much for your presentation and your lively discussion. And then we could actually move on to the next presentation, which is also the last for today. That is about the recurrent vertigo in childhood, vestibular migraine, probable vestibular migraine, and recurrent vertigo in childhood. which will be presented by Raymond van den Berg. Professor van den Berg is working at the Department of Audiology and Vestibular Laboratory in Maastricht in the Netherlands, which he heads. And he has been a very active member in our classification committee, not only in the recurrent vertigo of childhood subcommittee, but also in superior canal and presbyvestibulopathy. But today, his job is to present the work on the recurrent vertigo in children. And I think the organizer could now launch his recorded presentation, and then he will be with us for the answer and the discussion.
Welcome everybody, and thank you very much for this invitation on this pre-Bárány meeting. I'm Raymond van den Berg, ENT surgeon in the Netherlands, and together with a whole team, we made this consensus document about vestibular migraine of childhood and recurrent vertigo of childhood. And I will discuss this document now with you. Let's go to the slides. So I hope the slides can be seen. If not, let me know. So if we discuss vestibular migraine of childhood and recurrent vertigo of childhood, this is, as I said before, really a joint effort of a whole team. And this team involves people from all over the world and with also different specialties. So you see ENT is represented, neurologists are represented, all members of the Bárány Society, but we also did it together with the International Headache Society. So if children present to you at the office with dizziness or vertigo, we can think about many vestibular disorders in children, varying from central vestibular disorders to peripheral vestibular disorders. And there are many ways how to test them. But one specific entity that we want to address are the recurrent vertigo in children that is untriggered, so which happens spontaneously. And previously, in the past, it was called benign paroxysmal vertigo of childhood. But goal of this presentation is actually that we want you to a little bit forget this entity, because we want to propose different entities that might maybe better explain what's happening in these children. Because when children present with vestibular disorders and recurrent vertigo that just happens spontaneously, there are many challenges that we face. First of all, regarding benign paroxysmal vertigo of childhood. Because if we look at that entity, different criteria were discussed in the past. So it means that if you diagnose a patient with this, depending on which clinic you are, you might see different patients, but you all call them benign paroxysmal vertigo of childhood. So that's not favorable, especially not when you try to do research, because you have then a heterogeneous population. Furthermore, from the Bárány standpoint, when we refer to paroxysmal, we refer to attacks that have a duration of less than 1 minute. And in BPVC, the attacks can last more than 1 minute. So that's not very logical. And also, if you look at all these data, there is not really any hard data in literature about these type of benign syndromes. So if a child presents to you with recurrent vertigo that happens spontaneously, one of the other challenges is that you don't know whether it's linked to migraine or not, because children are so young that maybe they have not developed all the migrainous features if they would have migraine. So if they present with vertigo, you don't know whether they will have migraine maybe 10 years later when they're 15 years old or something like that. So if you look at these entities, we know that some of them are linked to migraine, but some also never develop migraine. So therefore, we think it more like a spectrum in which migraine can be absent or migraine is fully present. So therefore, children who present with recurrent vertigo that happens spontaneously, we actually try to classify now these syndromes, and we don't think about Meniere's disease and BPPV, and we approach it really like a spectrum, in which again, the presence of migraine can be fully present or it can be fully absent. And the idea behind this is that eventually we can be helped in clinic to really look at our patients and be able to give them a proper diagnosis, but it also facilitates research. So we can look at relationships between symptom clusters, and maybe there are subgroups within this population, and we can eventually investigate what's the likelihood in certain type of patients to eventually develop vestibular migraine. So therefore, the document describes this spectrum, and the spectrum consists of three main entities. First, vestibular migraine of childhood. Secondly, probable vestibular migraine of childhood. And thirdly, recurrent vertigo of childhood. And we are aware that recurrent vertigo of childhood is also a heterogeneous population in which you have subgroups that might be linked to migraine and subgroups that might not be linked to migraine. And therefore, if you look at it from a spectrum point of view, and you look at these three entities, you have entities in which migraine component is fully present until possibly absent. So what are the criteria of vestibular migraine of childhood? Well, vestibular migraine of childhood, the criteria are exactly the same, almost exactly the same, as in just regular vestibular migraine. So you need to have at least 5 episodes of vestibular symptoms. You need to have a current or past history of migraine. And at least half of these episodes need to be associated with migraine features. The only difference, of course, because we are talking about childhood, is that we said, okay, you need to have an age of below 18 years old. So far, this is almost exactly the same as vestibular migraine. But again, we are really aiming at defining the whole spectrum. If we go to vestibular migraine of childhood, we made some alterations because you need to have at least 3 episodes and not 5. And the reason why we decided on 3 episodes is that if you look at children and their parents, they often seem to look for help much faster than adults. And then you already try to help them in a certain way. And therefore we said, okay, for children, because they're not old and didn't have many episodes like adults, we said 3 episodes might be enough to already think about probable vestibular migraine of childhood. Furthermore, the criteria are exactly the same as probable vestibular migraine, except that again, the age needs to be below 18 years old. And then we have the third group. And the third group is recurrent vertigo of childhood. And this is actually the group of patients that have episodes with vestibular symptoms in which none of the criteria for probable vestibular migraine or vestibular migraine are present. So this means that this is the group in which you cannot find any migraine features, but they just have episodes of vertigo. But what we changed is that in this group, you do not have a minimum of 5, but of 1 minute. And the reason is that even within our group, people defined the previous benign paroxysmal vertigo of childhood already different. Some said it needed to be at least 5 minutes, others said, no, it's much shorter than 5 minutes. So you see, this entity is not yet fully clear. So this recurrent vertigo of childhood is also probably a group with subgroups, but this replaces the benign paroxysmal vertigo of childhood. And again, this is episodes of vertigo from 1 minute to 72 hours in which you cannot find yet any migraine criteria. Because be aware, children are so young, so they can even develop migraine features later on. So children might start with being classified as recurrent vertigo of childhood, but maybe when the disease progresses, they eventually end up with having probable vestibular migraine or vestibular migraine of childhood. So therefore, this is a group in which we are at this moment not yet sure how it fully consists. So this is really necessary to facilitate more research. And this heterogeneous population might have, again, subgroups linked to migraine, but we are also fully aware that some subgroups within this entity might not be linked to migraine. So how can you diagnose it? Well, as always, use the criteria, because history taking is still a key aspect of the diagnostic process in vestibular disorders. And next to history taking, of course, also in children, you just need to perform a thorough examination of the balance and eye movements, including head impulse test and convergence testing. But there are some reports, especially from France also, that ophthalmological problems might lead to dizziness in children. So if you suspect some things like a convergence insufficiency or refractory error, make sure that you perform some further neuro-ophthalmological examination to rule out or to treat any of these things. And again, of course, if you find any abnormalities in neurological examinations, then you think about totally different diagnosis. And regarding differential diagnosis, varying from central to peripheral, you will see here just a table with some of them. And this is not, of course, all the differential diagnosis, but these are many of them. And what you can already see, if you think about recurrent vertigo of childhood, vestibular migraine of childhood, or probable vestibular migraine of childhood, that they can be differed quite well already by history taking in many of them. Because if you focus during history taking on timing, triggers, and accompanying symptoms, you will see that many of them will not look at vestibular migraine or recurrent vertigo. For instance, if you look at vestibular paroxysmia, typically the attacks are less than 1 minute. While in Meniere's disease, the accompanying symptoms like oral symptoms should not be present in children with recurrent vestibulopathy of childhood. So therefore, history taking is crucial, and your additional physical examination can also reveal other things like central neurological signs, as in episodic ataxias, in which you might find oculomotor abnormalities between attacks. So for the future, what to do with these criteria? Well, I think it's important that everybody adopts these criteria. So try not to think about benign paroxysmal vertigo of childhood, but try to replace it by recurrent vertigo of childhood, and think about the whole spectrum in which migraine is fully present until fully absent. So you can just implement them in your clinical practice. But what we really want to do is that everybody working with children, that we encourage them to perform research on these groups, and especially on the group of recurrent vestibulopathy of childhood, because we want to know much more about which subtypes are present in that group, and how are they linked to migraine, and how will children eventually develop migraine later in life, or maybe not at all. So therefore, this is really an encouragement to everybody. If you have the possibility, try to perform research on this group. So to conclude, the new criteria do not think about benign paroxysmal vertigo of childhood anymore, but try to think as a spectrum: vestibular migraine of childhood, probable vestibular migraine of childhood, and recurrent vestibulopathy of childhood. And be aware that even the recurrent vertigo of childhood has different subtypes. And we really want to systematically perform research to these subtypes. Because if we understand them better, eventually maybe we can revise the criteria and give a more specific indication about how to categorize children with these deficits. We discussed the criteria about recurrent vertigo of childhood, and I really thank you very much for your attention. And if you have any more questions, please feel free to let me know, and you're always also welcome to contact me by email or phone or anything like that, and I'm happy to explain more about it. Thank you very much.
Thank you, Raymond. And again, unfortunately, we cannot really clap, but you gave I think, a very clear and didactic talk. And I don't see a question. Yes, was one question by Antonio Lopez Escamesi. He asked about the investigation of familial aggregation of recurrent vertigo of childhood, especially in those who are not linked to migraine.
Yes, thank you very much for your words and also for the question.
Mm-hmm.
Did I consider to investigate it? Yes, actually, we also, our colleagues, we already considered a lot to investigate. But it's very difficult to really get this research going because, first of all, we now define it as being some kind of new entity. And children, although we see quite a lot of children, you just want to increase numbers as much as possible. So in order to really investigate it properly, we are looking for a big cooperation with a lot of clinics in which we all screen the children, diagnose them, and also try to follow them up in a more structured manner to see what type of symptoms, etc., will develop later in life. And of course, family history is one of the most important aspects because family history regarding migraine, balance disorders, hearing problems, and epilepsy, that's one of the standard questions that we always ask to all our vestibular patients, including the children.
Yes, I must say that I was positively surprised how quickly and how smoothly this definition went through, because it took less time or as most other definitions. And I am pleased because if we look at the present classification of headache disorders, the vestibular migraine in adults is still not fully in it. It is still in the appendix, whereas the benign recurrent vertigo of childhood, which has a much less strict definition, is in it. And as you said, and the reason why vestibular migraine is not yet that easily accepted is because many headache experts are still skeptical about it. And then you are surprised that on the other hand, we have a very loosely defined recurrent vertigo, which is in the classification as a migraine equivalent, where, as you rightly say, that might be true, but we are sure that not everything is migraine. And the few studies which have followed up children who develop that syndrome, not everybody developed migraine. So we are pretty sure that they are not all migraine. And we would like to know what they really are.
Exactly.
Isn't it? Hold on, there is, I think there are still questions coming in which are related to the previous talk. Yes, there's a question about, I think, treatment of vestibular migraine in children. If I understand the question well, of Iveta Cheskova. Could you comment on lifestyle changes, diet, prophylactic treatment in children? For how long, which ones?
Yes. First of all, I'm not sure which entity of the three you are referring at, but maybe when we think about the recurrent vertigo of childhood. Well, first of all, in the past, we knew that with the benign paroxysmal vertigo of childhood, there was some kind of link with migraine. So there were indeed people who just started migraine prophylaxis. But I would say the first is to give them a diagnosis, because really the counseling and explaining what's happening is often already one of the most important treatments that you can give, because a lot of parents think that there is something really dangerous going on with the child. And if you explain that it might be a more benign disorder that's happening, although we're of course never sure whether it's fully benign, therefore we didn't put benign this time in the recurrent vertigo of childhood, but it's very likely in many children to be benign, then they are already very happy. And then the question is, do you really need any additional treatment? Because that depends, of course, on the severity of the attacks and how much the child suffers from it, not how much always the parents suffer from it, but the child itself. And then what you could think about if you have the recurrent vertigo of childhood, that you do think about migraine prophylaxis, but that might maybe be also a little bit cultural, because for instance, in our country, people don't like to take any medication. Well, if you go to a country really next to us, there everybody likes to have medication. So it's also a little bit what is your patient population that you're looking at? Well, in our country, we don't give too many medication to the children, but I know that some people try, for instance, some migraine lifestyle changes. That's also something that in our country is less well performed, those lifestyle changes, because if you look at literature, they are not fully evidence-based. And if that doesn't work, you can think about migraine prophylaxis for children. I hope that's a little bit an answer to the question. If not, let me know.
Well, we got a comment from John Oates from Cleveland, if I remember, if it is the John Oates I met there many years ago. He obviously is seeing many of these cases who will start off with benign recurrent vertigo without the accompanying symptoms of migraine, and then they will evolve to one of the forms which are linked to migraine. Proposes a registry. Well, registries will always be nice to collect. That is for sure. Yeah, he says adults respond well to lamotrigine. That is also my experience. I don't have as much experience in children, I must say. Maybe John could comment on that. And then I've got a question here about how to deal with the case if the symptoms and signs are typical, however, the episode was not adequate for diagnostic standard. I think you can read the question yourself.
Yes.
I don't fully understand the question. I think it is the problem is when you have a first episode, then you don't know if it is a recurrent episodic disease, obviously. The episode, the symptoms of the episode itself are as such quite non-specific, aren't they?
Exactly.
Yeah.
Exactly. First of all, I want to already say that I would really enjoy the registry, because I think that was a proposal. So feel free to contact me, then we could start it. So. But I must admit, Alexander, that I do not exactly understand also the question what's really meant with that. So if it can be clarified a little bit more, then I would be more than happy to answer it.
Okay. There's a comment here on the association with paroxysmal torticollis of childhood. I think that some also consider that as a migraine equivalent, and it could be a vestibular equivalent with these vestibular cervical reflex or kind of nystagmus going on. I think that is quite plausible, but it is eventually not very common in my experience, at least. Then we have here questions. Could you speak a little bit about the use of the Virgin's test? Yes, there's also a question I wanted to raise, because in our group, we had Sylvette Wiener-Vacher from Perez, and that is a point she insists a lot on, that we should look into that issue. But maybe you comment further on that.
Yeah, so if you look at the differential diagnosis, we made a list of it. And one of our members of the committee, Sylvette Wiener-Vacher from France, is really an expert in testing children. And it's, I think, she spent her whole working life on testing vestibular function in children. And what she noticed, and she also made a nice paper about it, is that if you test nicely the oculomotor system, that some children who have, for instance, a refractory error, or when they have some kind of convergence insufficiency, and you try to correct it as far as possible, that those children stop having these attacks, so that it might help as the treatment of the attacks. So therefore, she really made a plea for make sure that you do a thorough examination also of the oculomotor system. And if you see any of these abnormalities, make sure that you also try to treat them, because it might help the child in getting rid of the symptoms.
Yes, I think that we should not neglect. And probably the children who grow up now with a lot of exposure to small screens might even have more often these problems as they used to have before. There is a comment, a small comment or a question, that in the IHS classification of 2018, they use the term benign paroxysmal vertigo and took away the childhood. It is because they have extended all these syndromes which were before claimed to be just occurring in childhood, that they can all occur also in adults, also the episodic vomiting and so on. And the question which relates to that is, will the classification of vestibular disorders and the classification of headache disorders unified in the future? That is absolutely our hope. And you might have missed it, but Stefan Evers, who is one of the leading people of the IHS classification, is actually a co-author of this definition for the recurrent vertigo and vestibular migraine in children. And I think at that level, at least, we have already consensus, I think. I don't know, Raymond, if you can confirm that.
We explicitly invited the International Headache Society to be part of the subcommittee, because we want, of course, to really merge the two entities together regarding this syndrome spectrum.
I see our colleague has now repeated his question to make it clearer. So first thing, first visiting pediatric patient, yes. What is your strategy? Well, strategy, I think, would be to reassure and to wait what happens.
Yes, and I think the main strategy is, because this is often also how I think this is an important point, because this is often also how you get, for instance, second opinions from colleagues, is that they say this child has vertigo, what to do, for instance. Mm-hmm. But there it's really important to perform a proper and complete history taking, in which you really look at the timing, the triggers, and the accompanying symptoms, in which we are, of course, aware that in children, they will probably, when they're very young, not say, oh, daddy, I have vertigo or something like that. But they can also show it differently, like they have episodes of unsteadiness, something like that. But the history taking really is always the first step. And if you then have an isolated case of vertigo, in which you do not see any other abnormalities, well, then at this moment, you cannot call it recurrent vertigo of childhood, because, you know, for recurrent vertigo of childhood, it needs to be recurrent. So therefore, this is an episodic syndrome that we described. So we really want to be sure that it's also happening episodically. So in the first case, when you expect it and you do not have any other red flags, we also explain the parents that it might be a single episode, but that it also might be the first episode of a syndrome, and that they should be aware of that. And when it happens more frequently, that they then need to come back. Although I must admit, but it might be maybe also depending on the country you're working with. In our country, we as the specialists do not see the children after one episode right away. Often there are other healthcare providers, like primary healthcare providers first, before they end up in our hospital. But that might differ between countries.
Yes, that's probably recruitment, could be a recruitment bias. Yeah, we got a comment by David Newman-Toker of a patient of 11 years old with a persistent dizziness and vertigo, who had seen obviously a lot of professionals and was labeled psychogenic, and then the symptoms vanished after when he closed his eyes, and he had an irregular corneal topography and got hard contact lenses, and with that his vestibular symptoms then disappeared.
I think this is exactly the case that Sylvette Wiener-Vacher tried to make within our committee, and why we explicitly emphasize also the oculomotor testing.
Yeah.
And testing of the eyes, of course.
Okay. I see that there are at the moment no further questions. Well, I think then I think we can conclude for today. I would thank very much the speakers of today and the active participation of the audience in the questions and the discussion. So for all those who are interested, we meet again tomorrow at the same time. And I would just like to answer one question, which was also coming in the chat room, is will these presentations be accessible offline when you want to look them in peace later again? The answer is yes, but I cannot tell you the exact details, but they will be accessible. I don't know if the organizers will want to say another last word before we close for today.
Thank you very much to all of you, and of course it has been a very interesting meeting, and I see that this is a very bright society, because I have never seen such a long roundtable questions as today. And regarding the question, yes, the video shall be on Monday on the website, the private website of the website for each one, so it will be available. We have had some problems, and I think most of them have been of coming into the session by the problems with the connection and spam and things like that. But I hope tomorrow will not be that way. So thanks a lot, and see you tomorrow.
See you tomorrow. So thank you. Bye bye, everybody.